You ready? We're live. All right. We will go ahead and call this meeting of the Senate Labor, Health and Social Services Committee meeting to order. And if we could take the roll, please.
Senator Crum.
Excused. Senator Crum has 2 meetings going on right now, so he's left us some absentee votes.
Sure. Senator Hutchings.
Here.
Senator Scott.
Excused.
Senator Steinmetz.
Here.
Chairman Brennan.
Here.
Madam Chairman, we have a quorum.
All right, thank you. First up for our consideration today will be Senate File 19, epinephrine delivery methods. And we've got Senator Rothfuss here to explain this bill.
Thank you,
Welcome.
Madam Chairman. Thank you, committee members. Senate File 19, epinephrine delivery methods, simply goes into statute into existing policy and updates the language around epinephrine, where currently in statute, it tends to favor the concept of an EpiPen. An epinephrine auto-injector is how it's typically called out in statute, single dose concepts. There were requests to generalize this, recognizing that at this point in time, while EpiPens are still common in the market, there are alternative delivery systems. For example, nasal, you can now just inhale it, the epinephrine, and single-use ampules and other techniques. So this does not change any policy. It just goes into statute everywhere where we use that phrasing and adjust the phrasing such that it's generalized to any form of epinephrine delivery. That's the entire bill, Madam Chairman.
Thank you. Committee, any questions?
Just one.
Senator Steinmetz.
So, thank you, Madam Chairman and Senator Rothfuss. It looks to me like this will alleviate the need for us to do this again because it says or method. Is that correct? Because I just wanted to be clear for citizens listening out there and for my own edification.
Madam Chairman, Senator, yes. So we wrote this as broadly as we could, basically to try and future-proof it.
Thank you. Any further questions for sponsor of the bill?
Yeah.
Okay. Anybody who would like to provide public comment on this bill? Welcome. Go ahead and state your name and.
Thank you, Madam Chair. My name is Nick Bellack. I'm with the Wyoming School Boards Association. And I want to just say that WSBA stands in support of Senate File 19. Severe allergic reactions are unpredictable. They're time-critical medical events. And this measure does modernize the statute by recognizing all the federal approved delivery methods, and it ensures that students receive rapid and life-saving intervention regardless of the device type. At its core, this is a student safety bill and falls in direct line with our advocacy agenda item number 5, which is supporting safe and supportive schools. So this is definitely what's best for students, in our opinion, and we stand in support, and I'll stand for any questions.
Committee, any questions?
Thank you.
Okay, thank you. Right.
Hi, Chairman Brennan, Senators. My name's Janet Farmer. I work for Laramie County School District number 1 as the Health Services Coordinator, but I'm here today representing school nurses across the state as the Wyoming Director to the National Association of School Nurses. We are also in favor of this bill. It would provide a measure of safety, but also gives school nurses and districts across the state the option to use the alternate method. I did bring a couple of props. The current one that is in statute right now is the EpiPen. It's the auto-injector. There is some anecdotal evidence out there that people or anyone hesitate to use it simply because of the needle. The needle is very long, and so they hesitate because of that. The newest version is, the commercial name is Neffy, but it actually it's very small like this. It goes into the nose. It's absorbed through the nasal membranes. So it's easier, it's faster, and at some point it will be cheaper. From what I understand, it's cheaper now. So we are also very much in support of this bill, this change.
Thank you. Committee, any questions? Okay,
Madam Chair, Tony Decklever with the Wyoming Nurses Association, and we, along with our colleagues at School Nurses, we do support this bill. Epinephrine, it can be a lifesaver for people that are having an anaphylactic reaction. And I have had patients who have had the epinephrine pen and are hesitant to give it to themselves because they're so scared of the needle. So having another alternative to be able to deliver epinephrine is a good thing. And having it in schools so that the nurses can provide this to their students is a good measure. So we are in full support of this bill.
thank you. Committee, any questions, Ms. Steckler? Yes, Senator Hutchings.
Thank you, Madam Chair. Tony, you said something just a moment ago, having it in schools. Are you saying that the schools will have them there to administer the nasal sprays, or the student can bring theirs in and have it administered?
Madam Chair, Senator Hutchings, both. So currently, schools have an option to opt in to the epinephrine program where they have epinephrine that is stocked at the school. And when a student comes in experiencing or exhibiting symptoms of a severe allergic reaction, then they are allowed to give it to them.
Committee, any further questions? Right, thank you. Anybody else that would like to comment on this bill? Do you have anybody online for this bill? Okay, with that, we will close public comment. Committee, what is your pleasure? All right, it has been moved by Senator Hutchings and seconded by Senator Steinmetz. All right, committee, any discussion on the bill? Any amendments on the bill? Okay, with that, we will call for the question on Senate File 19, epinephrine delivery methods.
This is a roll call vote for Senate File 19. Senator Crum,
Senator Crum has left an absentee vote of aye.
Senator Hutchings,
Aye.
Senator Scott,
Aye.
Senator Steinmetz,
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 5 ayes.
All right, Thank
Madam Chairman.
you.
Thank you, senators.
all right. Committee, next up for our consideration will be Senate File number 23, outpatient examination and commitment length. And here to explain this bill is the sponsor, Senator Schuler. Welcome to Labor, Health, and Social Services.
Thank you so much, Madam Chairman. Good to be here and to see some different faces than what I usually see. So anyway, I bring you Senate File 23, outpatient examination and commitment length. This was actually a constituent bill that was brought forth by a judge over in my neck of the woods. And, you know, I'm sure we're a bit of an outlier over there because we have the state hospital. So we have a few issues that come up in our neck of the woods that may not come up in others. But he felt like we should take a look at expanding the list of examiners that are qualified to perform involuntary hospitalization examinations. Because once a notice is given, there's only 7 days, as you can probably see on page 2, to try and get that examination done. I don't know if it's the same in all of your areas, but there's only a couple of psychiatrists in my area. They all work at the state hospital. Very few psychologists in our area. And we're seeing fewer and fewer physicians. We're seeing a whole lot of PAs and APRNs. And so the judge said, is there any way that we could take a look at that statute and expand that? So I talked to a lot of people. And what I found was that in visiting with a couple of the PAs and APRNs in my neck of the woods, I said, would you be comfortable doing this? And they said, yes, for the most part. But if we didn't feel comfortable, we could say no, right? And I said, yes, you could. So you don't have to if you're asked to do that examination, but it does expand, you know, the choices that, you know, we may have in a certain area. In our area, like I said, we're kind of an outlier. And so by just expanding that, if you look on the bottom of page 2, it says that once they've done that, then the court can appoint any of those people to do a review of those findings. So let's just say a PA did the exam, and then all of a sudden a physician or the judge says, you know, let's have you take a look at this. By that time, maybe they can run a physician down and say, do you feel comfortable with these findings? And so if they do, then that's great. What I think would probably not happen is I doubt that a PA that did the exam would be asked to be the reviewer. They could, but I doubt that they would be. I would imagine that that's probably what would happen is they would ask somebody else to do the review. And again, if there needs to be a further examination, the judge could make that determination. And then over on page 3, this again came from the judge. He said, I really feel like for the directed outpatient commitments, it basically on page 3, line 9, it talks about just giving them 2 years to be able to kind of check with them and see how they're doing. He said, I really am seeing a lot of these folks that are not ready to be let go and not under our supervision after 2 years. So he said, is there any way we can just take that out and just ask that we can review it every 6 months until the court feels like this person might be ready to be back into the fold. So with that, committee, I'm happy to answer any questions.
Senator Steinmetz?
Thank you, Madam Chairman. Has there been any pushback? Because that's what immediately stood out to me was on page 3, the not to exceed 2 years. And I agree that we have seen an increase, I think, in situations like this and not a lot of rehabilitation in some cases. But I just wondered if there's any pushback there. Just that's a pretty big policy change, actually.
Yeah, thank you for that question, Madam Chairman and Senator Steinmetz. No, I actually talked to 2 of the folks. Well, I think, they're the head of 2 different places that we have in our community that deal with these folks and not the state hospital. And I said, how do you feel about it? And they said, we're seeing the same thing. We're seeing that we need more in-depth. Sometimes it's an issue with meds. That they're not getting the right medications to start with, so they end up having to change it. And this could be through a physician or whatever, but sometimes it's 3 or 4 times to get the right medication and then to make sure that they're doing what they need to be doing so that they don't become an inpatient person, at the state hospital. They're really trying to keep them in the community and keep them, stable. So I visited with 2 of the folks in our community that deal with a lot of these situations, and they felt comfortable with it.
Committee, any other questions? Senator Scott?
Madam Chairman, so this is dealing with outpatient commitments. What are the practical consequences for the patient here? Are we confining them, removing their liberties, or are we compelling them to take certain medications? What's really happening to them as a consequence of this? I'm trying to figure out whether having the somebody other than a medical doctor has the possibility of doing some real harm to some of these people, or is this just a fairly routine matter? Who's actually making the decisions here?
Senator Schuler?
Hey, Madam Chairwoman, Senator Scott, actually, the issues that we have mainly in our community, and I don't know if other communities are having the same issue, but some of our folks that are in the state hospital for a certain amount of time, and then they're deemed okay to go out into the community, and some of them do quite well for a year or 2, maybe 3, and then maybe they go off their meds, or maybe things happen in their life or maybe they, go out and start drinking, or who knows what. And then they end up back in jail or, in the hospital. And then we have to start the process again with the examinations. The hope is that when these examinations are done, that they don't end up back in the state hospital. The idea is to try to keep them as an outpatient, but some of them they don't seem to do well for X number of years. And so it's kind of a lot of those folks that are out there and then maybe do okay for a year or 2 that seem to sometimes fall into that gap where they just can't seem to be, stable. So all we're doing really is just allowing 2 other of our medical professionals to do examinations rather than physicians, psychologists, and psychiatrists. We're allowing the PAs and the APRNs now to do those exams because of the 7-day notice. Because once the notice comes up that we've got to give them an examination, what the judge has mentioned is his issue is that we're just not be able to get into a physician. We can't get into a psychologist. We don't have enough psychiatrists that are not working in the public They're at the state hospital. And so then we run afoul of the statute by not being able to get them an exam within 7 days. So that's the idea behind expanding into the PA and APRN world. I don't know if that answered your question or not.
Madam Chairman.
Senator Scott?
Madam Chairman. I still remain a bit concerned. And sometimes it's not the fault of these folks that are involved. You can get accustomed to a medication in a way that it ceases to be effective after some period of time and need to go on a different one. And I suppose that would be one set of issues. And I'm still trying to figure out how much are we dictating the lives of these people that are involved? And are we really getting the level of expertise we need? Should we do something about the 7 days rather than the type of provider we're having them see? I'm still groping with this, Madam Chairman.
Well, Madam Chairman,
Senator
one thing
Schuler?
I would say, Senator Scott, is that we're having a real issue in our jail, particularly in our jails. They're having to house some of these folks that are having issues where they've gone off their meds or just are not being able to handle being in society. So our jails are trying to deal with it. And so this really helps them. And so I'm not sure about other counties and other places if they're having the same kinds of issues, but it certainly would help our area.
Thank you, Senator Schuler. Any further questions? Senator Hutchings?
Thank you, Madam Chair. Senator Schuler, I too am just a little bit concerned about page 3, lines 6 through 10. Can you just narrow it down to me so I can understand what exactly is happening there?
Senator, sorry, Madam.
Go ahead.
Chairman, Senator Hutchins, could you mention which lines again you're looking at?
This is
Page
line
3?
6, the court shall,
Okay,
and then ends on lines 10, at least every 6 months.
okay.
What's happening? We're taking out 2 years, kind of like Senator Steinmetz was concerned about it. I'm broadening it, I hope, a little bit to
Yeah.
understand it fully.
Madam Chairman and Senator Hutchins, I think when I talked to the judge about this, because this again was his idea for this bill, and he just said, we're just not getting them cured and where we need them sometimes in less than 2 years. And so he said, by taking that out and letting us review it every 6 months, now it's the courts that'll be reviewing, because again, that's where they end up. They end up homeless, or they've caused a problem in the community and they end up in jail, or they end up in our ERs or whatever else. And he said, I just think the 2 years is kind of confining us and not giving us the time to really make sure that these people that are outpatients are getting healthier. So that was his ask.
You, Senator Schuler.
Clear.
Senator Hutchings.
Thank you, Madam Chair. So if I have it right, we're saying 2 years is too much time. Let's narrow it down to just reviewing these people every 6 months.
Madam Chairman, Senator Hutchins, no, it's the other way around.
Okay,
Before it was a 2-year deal, and basically after that, we just said, we sent them out and say, hey, you're done with the courts. Go be merry.
so now.
And now we're off. We're just taking that cap off.
Gotcha.
Senator Steinmetz?
Thank you, Madam Chairman. And I pulled up the rest of the statute. So in subsection B, it tells them whether directed outpatient commitment is appropriate. The court may consider one or more of the following. And I'm a little concerned at the broadness with this, especially in section 5. They have, the proposed patient is diagnosed with having mental illness. That makes sense.
Mhm.
And they have a few other things, but for the sake of time, in section 5, it says any other information concerning the proposed patient's need for outpatient care. And that seems awfully broad to take that cap off, because that could, any other thing. And so we're expanding who can decide this and then taking the cap off. I'm worried that's a little broad, because if you wanted to protest that, it would be difficult to do. So I would be comfortable with the bill if we left the not to exceed 2 years. there, but I don't know that I can support it without reinserting that. But do you have any, is there
Senator-
anything you can help me with on
Yeah.
that?
Senator Schuler?
Madam Chairman, Senator Steinmetz, I actually questioned the judge as well. And I'm comfortable if you want to go ahead and leave that in there, the 2 years. He's the one, again, the courts that have to decide that anyway. So to me, it seemed like it put an awful lot of extra on their plate to do it every 6 months, review, bring these people in and review. So I'm fine if we just take that out.
Any other questions?
Okay, we will open this up. Does the department, we will bring up the department to comment on this bill. Welcome.
Thank you, Madam Chairman, members of the committee. Stefan Johansson, Director for the Wyoming Department of Health. Was mostly here to answer any questions the committee had, but given the discussion, Madam Chairman, if you'll permit me just a few comments. Keep them specific to what's on page 2 and then what's on page 3. On page 2, what you're really seeing is, having been in this world for quite a while, overseeing the state hospital Title 25, you as policymakers are often dealing with the balance between the ideal and practical reality. Ideally, in these proceedings, as the statute envisions, communities and courts have a psychiatrist to review, at the very least, the final examination, and we all want that. But we know practically that's not possible in every community, especially in some of our smaller communities. So the statute also envisions the ability for a court to have that examination reviewed by a physician. And in this bill, what broadens is being able to have a physician's assistant, an advanced practice registered nurse, or a psychologist be that reviewer of the final examination that is used to determine whether someone is dangerous to themselves or others, mentally ill, and ultimately informing those commitment proceedings. So again, as the Department of Health, we certainly recognize that practical reality. We are fortunate to have 2 psychiatrists at the state hospital, with 2 psychiatrist positions vacant at the state hospital. So we know, even outside of Evanston and most of our communities, these specific providers are hard to come by. This is a practical reality that, to Senator Schuler's point, can be a tool for courts and communities to be able to exercise these proceedings in a timely manner. Again, in the spirit of the ideal, I think every judge and every community would envision that as much as you can, the appropriate resource and training in mental health or a mental health professional could inform or assist that physician's assistant or advanced practice registered nurse or psychologist. And we'll certainly work with communities to try to facilitate that the best we can. But that's essentially what is on page 2. And again, to the discussion you had a few minutes ago, I do think it's a practical reality that should be considered by the policymakers so that these proceedings aren't held up or in some cases dropped when they don't need to be because the appropriate professionals may not be available. So I think this can be a useful tool, but it's always a balancing act with, when you're dealing with individual civil rights, a balancing act on that perfect competing with the good. I know that's not the greatest testimony from your Department of Health director, but that's essentially what the state and your community struggle with. Secondly, Madam Chairman, on page 3, on outpatient commitment, just a brief history. This was put into statute probably 7 or 8 years ago as, again, a tool for communities and judges when inpatient commitment at our Wyoming State Hospital, the highest, most restrictive level of care for psychiatric medicine, may not be appropriate or necessary, but the mental health condition of the person is dangerous enough to warrant some sort of commitment on an outpatient basis. Many other states have implemented similar provisions, and this was something that was studied ad nauseum by several task forces and committees several years ago and ultimately put into statute. Again, it's a tool to have less restrictive level of care for folks who may need it and some recourse from the judicial system through Title 25 for judges to essentially compel folks to show up for hearings or check-ins. Are you following this treatment plan that has been agreed to? That can include medications. It doesn't always have to, but it has become in several communities a very useful tool to prevent the need for highly restrictive level of care, essentially locking folks up in the state hospital. So again, on the positive side, a really useful tool. But implemented differently across the state, sometimes upon discharge from the state hospital and sometimes before even entry or commitment to the state hospital. We don't have a firm stance on removing the 2-year provision one way or the other, but certainly appreciate the discussion that you had before, noting that even with outpatient commitment, you are dealing with civil liberties. It is a serious issue for individuals that are going through these systems. What made the Department of Health more comfortable is, as the outpatient commitment statutes already have in them, is that 6-month review that even with this bill would remain, and essentially directing the court to enabling the court to review that commitment every 6 months. However, Madam Chairman, through you and Senator Steinmetz, the discussion is worthwhile if that time-limited provision is worthy of repeal. Potentially considering an extension might be a compromise there. But again, I certainly in your Department of Health sees it both ways, that it can be a useful tool for certain populations in certain cases where that extended time of outpatient service may absolutely be warranted to prevent escalation to higher levels of care, but also with respect, noting that the original intent was to have some sort of time limit on the ability to compel someone for that type of treatment. And with that, Madam Chairman, happy to answer any questions that you have.
Thank you. One question on this part, on the not to exceed the 2 years. Do we have any data on the number of times that somebody hits that 2-year and so we're done with, and then they really could have benefited from a little bit more time?
Madam Chairman, it's an excellent question. Unfortunately, the outpatient commitment happens essentially outside of the state hospital. So we have very comprehensive data for Title 25, Title 7 individuals and patients that we serve, both in terms of their inpatient admission, their care, and their, in some cases, discharge on conditional basis or convalescent leave. The outpatient commitment is really a local tool, again, a beneficial local tool, but we don't have a comprehensive data set that we could academically answer those questions on the volume that have warranted an extension. We could certainly work with some of our counties or courts to see what might exist, and we'll follow up on that, but I don't believe we have that at the Department of Health.
Perfect, thank you. Committee, any questions for Director Johansson? All right, thank you. I'll just also comment on some of what Director Johansson talked about in that licensed, adding the licensed advanced practice registered nurses and the licensed physician assistant. Oftentimes, once these people finish school, and in the case of the nurse practitioners, they can even specialize in psychiatric areas once they're either in or once they're done with school. So they get training in school, and a lot of times these people specialize and will work with just this population of people. Director?
Madam Chairman, thank you. One more comment on that note, because it is important. Again, we were unsure if we should suggest this as an amendment, but conceptually for the committee's discussion, given what you're weighing here, on page 2, line 18, after psychologist, the committee could consider a direction that to include with certification as a mental health professional. Again, we hesitate to suggest that because, again, the practical reality of having these types of providers trained in that world may be limited in certain communities, but that there is precedent for that in other states who deal with similar issues in their commitment laws. I know for an advanced practice registered nurse to have that mental health certificate or mental health training, it can be 30 hours of continuing education. Chairman Brennan, you probably know more about this than I do. That's certainly possible. But again, would encourage the committee to consider that. We're happy to work with the sponsor, you all, if this were to hit the floor, to maybe provide examples in other states or some language suggestions, but that's something for you to consider.
Thank you. Did you have a question?
Yeah.
Okay, Senator Scott.
Madam Chairman, my question relates directly to that. We start doing comparisons with other states. Am I right in thinking we're having special problems in Wyoming, getting enough medical personnel? A combination of factors, Madam Chairman, the discrimination against Wyoming by Medicare, the fact that we voted to have legal services instead of medical services a few years ago, the difficulties in terms of just having enough volume of patients and the difficulties of finding jobs for spouses of some of these specialized people. They're all combining. Am I right in thinking we have to be careful about copying from other states because they may have a lot more providers than we do?
Director?
Madam Chairman, thank you. Senator Scott, yes, I think we would definitely hesitate caution on copying and pasting from every other state. I think Wyoming, certainly with its density of population and providers, we have some similar comparisons in our region, in the Dakotas and the Mountain West, with similar struggles in these particular legal areas, but certainly would not encourage to port over law from maybe more urban states with better provider density.
Any further questions? All right, thank you. Anybody from the public who would like to testify on this bill? Welcome.
Thank you. Madam Chairman, members of the committee, Sheila Bush with the Wyoming Medical Society. We are, I guess, divided a little on this bill, but overly supportive. We have a tool that we can poll our members on issues like this. So we did that for this bill. And just under 70 of our members responded, the majority of which were in support, with the caveat that some added language be included that would specify the mental health training. Because this is the final hearing for someone before they are institutionalized, and decisions are being made about their lives that have lifelong impact. Careers are ended, relationships are ended. These are serious consequences for folks when they are at the 110 hearing and being involuntarily hospitalized. And so our recommendation, and in an attempt to sort of work with the sponsor and be supportive of it, understanding conceptually the need for this. And again, Director Johansson said so well, the balancing act that's required in Wyoming, but remembering at the end of the day, this is an individual's life who's forever changed. And so there are a couple of, there's a psychiatric nurse practitioner designation, which would be easy enough to include. And then for PAs, there is a similar, the National Commission on Certification of Physician Assistants, the NCCPA, offers a certification in mental health that could be included. And we'd be happy to work with you if you felt like that would be amenable or satisfactory.
Any questions? Senator Hutchings?
Thank you, Madam Chair. Mrs. Bush, just wondering on page 2, line 17, we have a licensed advanced practice registered nurse and licensed physician assistant. What qualifications do you think they have that will enable them to carry on this position? Thank you.
Madam Chairman.
Yep.
Senator Hutchings. So an APRN is an elevated degree for nursing, and I hope Tony Decklever is maybe still here because I'm about to say things I don't know very well. But APRNs can specialize in a number of different areas. It's just an elevated training, like most often, I think it's a doctoral degree for an APRN. Is that correct?
It is.
Senator Brennan.
It is correct. Most places are moving more towards, yes, a 3-year doctoral degree. I think there's some places where you can still get a 2 years master degree. Mrs. Decklever is going to come
That's so great.
correct all of us, but it
yes.
is an advanced.
Yeah. To answer your question, you can specifically specialize in just psychiatry and mental health.
Madam Chair, Tony Decklever with the Wyoming Nurse Association. The University of Wyoming offers a psychiatric nurse practitioner program. It is a DNP and it does specialize in psychiatric care.
Perfect. Thank you for pointing that out. Any other questions? I do have a question. Do you feel that we need to call out these specific, or can we write the language something like with the certification of mental health professional and broaden it so that if there is more degrees out there to come, it would, or other certifications that would capture that in the future?
Madam Chairman, members of the committee, I think that that would be great. Truly, our goal is to be supportive in recognition of the need, but to safeguard as much as possible for that patient who's having these decisions made about them. I think it's important to know that at the very beginning of the Title 25 statutes, an examiner is a pretty long list of providers that are available to the judge to make those determinations, including family marriage counselors are included in the definition of examiner that is used throughout the act. It's not until you get to this section being amended in the 110 area where someone has made it through several different levels to get to the 110 hearing. And so it has always been that if you're at that point and they really are deciding whether or not you're going to be hospitalized involuntarily, that there be a psychiatrist, a physician, or a psychologist, at least as part of that conversation. And so today, the way it works is any of those healthcare professionals defined as an examiner can do that 110 hearing. The only thing is today, the way it works is if someone other than a physician, psychiatrist, or psychologist is the one who does that, the trigger is that the courts shall have a review of that done by a physician, psychiatrist, or psychologist. So that's what's being proposed for a change, is that if today it would say that if a PA or a nurse practitioner does that, the courts would not have an automatic trigger for the review. And then if someone else did that, a PA or a nurse practitioner could also be one of the individuals conducting that review of the exam if someone else had done it. So I don't know if that helps or makes it muddier, but that was just our concern, that when you are at the very end of this road, we'd love for someone to have some specialized training in mental health involved.
Thank you. Yeah, Senator Hutchings.
Thank you, Madam Chair. Listening to all this, I understand what you're saying, but I think, and I may be wrong, maybe Senator Schuler can clarify, they may not have those specialties on that side of the state. So that's why they're asking for this now. So with that, knowing that you may not have the DPN or the psychologist like they really want, is this one of the best options for them?
Madam Chair, or Senator Hutchings, I'm not sure. I think that's a decision for you all to make. I think that there's also telehealth to consider, and I think that that is available to the courts, and I would love to be corrected if that is not available. But we have done a lot of work in the healthcare scene over the last 10 years, especially with technology and the availability of some of those higher level providers to be made available. So this may not be the only solution. It could be that today we could baby step in and put some of those safeguards for mental health. And then if it really truly doesn't work and we can't utilize some of the technology available, then we revisit it.
Senator Steinmetz.
Thank you, Madam Chairman. So I want to see if I'm understanding this right. At the beginning of this process, it's kind of like the big part of a funnel where there are a lot of people that can get you started into this process. But when we're coming to the part where you're being voluntarily committed, locked up against your will, the funnel gets pretty narrow, and we have some gatekeepers there to make sure that this is not happening and to safeguard people's due process of law and their right to, have a fair hearing and make sure that this is, they have to be locked up for their own safety and the safety of others and that type of thing. And that's what concerns me about that statute in that one part is so broad. It says any other thing that you could be looking at. So as far as the very end of the funnel where this is actually happening, they're making a determination whether you're gonna be locked up. To have some kind of mental health certification, you're saying would be appropriate when you're dealing with people's rights to be a free human being on the planet.
Madam Chairman. Senator, hi, sorry, Senator Steinmetz, that's also my understanding. Yes, everything that you said is how I also would understand this to be kind of conceptually characterized. If it were me or a family member of mine, I would sure want to make sure that I had the highest level of faith and trust that someone holds that certification and understands what's really at stake before they make a decision that has such impact.
Thank you.
Committee, any further questions? Ms. Clover, do you have any further comments?
Chairman Bremen and senators, the Board of Nursing really watches out and makes sure that advanced practice registered nurses are practicing within their specialty area. And so if you put in here that it would be a psychiatric nurse practitioner, then it would be those that have been trained in that realm that would have, that would be able to do this.
Perfect. And then do you feel that the wording close or similar to with certification of a mental health professional would capture that psychiatric nurse practitioner?
Chairman Brennan, yes.
Thank you. Committee, any questions?
Madam Chairman, how
Senator Scott.
common are these mental health additions to on the licensed nurse practitioner? Is that something you see frequently, or are there very few of them in Wyoming?
Chairman Brennan, Senator Scott, there are very few. Chairman Brennan, I would just add a little comment. There are probably more mental health nurse practitioners than there are psychiatrists. So many of the facilities that use mental health providers, they glom onto our mental health nurse practitioners quickly because they're easier to get than a psychiatrist, but there's not as many as we need.
Yes. Other questions? Great. Thank you. Any further public comments? Any further public comment? All right, with that, we will close public comment on Senate File 23. Committee, what is your pleasure?
I'll move the bill, Madam Chairman.
Okay, moved by Senator Scott, seconded by Senator Hutchings. Okay,
I have
Committee.
some amendments if you.
Senator Steinmetz.
Madam Chairman, I have 3 amendments on page 2, line, I guess it would be 14. 15 after assistance with certification as a mental health professional would be my amendment. And the same amendment would be line 18 after assistant.
Okay, I'm gonna track that in here in my brain, so.
So it would say a licensed advanced practice registered nurse, a licensed physician assistant with certification as a mental health professional or a licensed psychologist. It would go on.
Okay, nope, that makes sense. I believe that works. Okay,
And that would work on the same way on line 18 after physician assistant. And then on page 3, I would reinsert the stricken language on line 9, not to exceed 2 years. I feel like it's really important that if we're dealing with these types, and I know this is outpatient, but if we're going to basically put a pause on people's rights for it's important to have a time frame which we don't exceed. And then if they have to start over again, so be it, but I think they deserve that kind of scrutiny of their situation.
Committee, any,
Madam Chairman. Can we divide the amendment?
yes, I think we can divide that amendment, Senator Scott. So,
So that we deal with the 2-year issue separate.
okay. All right, I think that's a great idea. So this amendment was moved by Senator Steinmetz, second by Senator Hutchings. We're going to take up the first part of that, which is to add the language with certification of a mental health professional as a, yep, you're right, as a. Just in looking at the way that this is, and maybe we just need to ask LSO if it works by putting it after a licensed physician, because we have licensed physician, licensed psychiatrist, then we have the licensed advanced nurse practice APRN, a licensed physician assistant, or a licensed psychologist. And so I don't know if it needs to go, I mean, we know a psychologist is licensed in the mental health. Does that make? Yeah. So do you have that amendment? But if it would be friendly to give latitude to LSO to put it in the correct spot.
Yep.
Madam Chairman, just to confirm, so initially it's the amendment was to put it after licensed physician assistant, is that correct?
Correct.
But to make it a conceptual amendment so that the LSO drafting attorneys can amend it as they deem necessary.
Yeah, so
Is
they
that-
can move that if it needs to go in a different,
I understand, Madam
Spot.
Chairman.
okay. If you're. Okay. Any discussion on that amendment?
Madam Chairman. I think I'm gonna vote against this portion of the amendment because I think in an ideal world, we would do it and apply it to the registered nurse advanced practitioner as well. But I'm afraid we have simply been hostile enough to medical professionals that we do not have enough of these people. And that this is something we probably can't afford.
Okay. Any further comments on the amendment? Okay, all those in favor of Senator Steinmetz's amendment, please signify by saying aye. Aye. All those opposed, no.
No,
That amendment fails.
Madam Chairman, the second half of the amendment on the restoring the 2 years.
Yes, Senator Scott.
Madam Chairman, I would speak in favor of this. I think it, having the 2-year limit on it is probably a good idea. You might stretch it out a year or two, but I think just removing it entirely, even with them having to come back every 6 months for review, is, I think we're probably going one step too far. So I support this amendment.
Okay. Further discussion on the amendment? Okay. I am going to be a no vote on this amendment, as I feel like it would be appropriate to probably move this out a few years. But if that's something that we can always look at that too and further down the line. So all those in favor of Senator Steinmetz's amendment that we keep in the not to exceed 2 years signify by saying aye. Okay, all those opposed, no? No? That amendment passes. All right. Do you have all of that? All right, perfect. All right, committee discussion on the bill. Senator Steinmetz.
Thank you, Madam Chairman. Um, I'm going to be a no vote on this bill without adding that certification. I just believe it's really important that a mental health certified person is making that final decision when you're dealing with people's due process of law and their civil rights. So I'll have to be a no on this bill as it was failed to be amended to where I could support it.
All right, thank you. Senator Hutchings.
Madam Chair, I'm just wondering on lines 18 where it says, these, particular specialties are allowed to make a decision, but then a licensed psychiatrist has to review the findings of the examiner and conduct a further examination, kind of, help Senator Steinmetz out a little bit. I don't know, just wondering.
I think it's a or on lines 18. So it's any of these, any of those that are listed through
Yeah.
13 through 18.
Madam Chairman,
Senator Scott.
speaking on for the bill, I think in a better world, I would agree very much with Senator Steinmetz on this. Unfortunately, we're having troubles in Wyoming getting enough medical professionals, and if we can't find them within the 7 days, I don't know that we turn dangerous people loose or we clog the jails with people that are waiting for hearings, but to make the system work, we need to broaden who can do it. I don't necessarily like it at all, Madam Chairman, but I think we have to realize the extent to which we are having a problem with adequate medical people in Wyoming.
Thank you, Senator Scott. I just some of my thoughts and comments on this bill. I will vote to move this bill forward. One, this is the first step in several readings that this bill can go through. And so I think there's further discussion to be had on these two things. And second, while we don't currently have a language in there with the certification as a mental health professional, I do believe that there are advanced practice nurses and PAs that are, and I know that there are in these areas that work with these types of populations consistently. And so I believe that we should advance this bill, get it up on the floor for a good debate in this area. Further discussion? Okay, with that, we will call for the question.
This is a roll call vote for Senate File 23 as amended. Senator Crum,
Senator Crum has left an absentee vote of aye.
Senator Hutchings,
Aye.
Senator Scott,
Aye.
Senator Steinmetz,
No.
Chairman Brennan.
Aye.
Madam Chairman, that is 4 aye and 1 no.
Right. Thank you. Okay, next up for our consideration is going to be Senate File 57, Transparency in Hospital Pricing. This is my bill, so I'm going to go ahead and I will walk us through this bill. I will start by saying that this is very similar to a bill that we saw come through the legislature last year, but it had some issues with it that did not work very well for the hospitals. So we've reworked this bill because we know that hospital pricing transparency is a big issue. We all have our stories of going to the hospital and then having a bill that we didn't expect the number to be what the number was or whatever. So that's why we have this bill.
Madam
Yes.
Chairman, may I make a suggestion? Usually the chairman turns the floor over to I would suggest Senator Scott to run the meeting while you present your bill.
We can absolutely do that if you would like.
Madam Chairman, we can, or we can just do it the way you're proposing. It works just fine.
I've seen it done both ways. I think I'm happy to go down to the, I'm happy to go down to the front and explain this bill. Senator Scott, I will turn the chair over to you.
I wouldn't bother. Okay, Madam Chairman, proceed to explain the bill.
Senator Scott, members of the committee, thank you. So as I was saying, we all have stories on hospital service pricing, what that looks like, what we've come out, what we've gone in expecting, and what we've come out paying for. And so that's why we have this bill. And I will go ahead and walk us through this bill. Page 1 is the title of the bill. In sections 1, we create 35-1501 and 35-1507. If you turn over to page 2, we have the act. This act shall be known and may be cited as the Hospital Price Transparency Act. On lines 12 of page 2, we start with definitions. Those definitions continue on page 3, 4, 5. And then on page 6, starting with line 6, we have the shells of what a facility shall do. So they're going to maintain a list of standard charges. And there's going to be a list, the list will have to have a subsection for not less than 300 shoppable services provided by this facility. This does follow what is happening at the federal level with hospital price transparency. We go on to talk about all of those lists, what the standard charges are, what the codes are on page 7. Page 8 continues that, along with page 9. Things like they have to be searchable. Then on page 10, we get to the monitoring part, so that the department can monitor each facility's compliance with this requirement. And it gives them the ability to do that. And then on page 11, we start into the steps of what is going to happen to a facility as if they violate this. They'll have to come up with a corrective action plan. And then if they don't come up with a corrective action plan, then we have penalties over starting on page 13. So the first offense within a 12-month period would be a $100 per day. For each day, the department imposes a civil penalty under this section. The second offense would, within the 12 months, would be $500. And then for third or subsequent offenses, it would be $1,000 per day. And then we have the legislative recommendations where the department may propose to the legislature any necessary recommendations for amending this act. And then on page 15, we have the conditions of monitoring or revoking a license if these are not adhered to. Section 3 gives the Department of Health rule-making authority. And then section 4 says that except as otherwise provided by subsection B of this section, this will go into effect July 1 of 2026. Sections 3 and 4 of this act are effective immediately. And with that, I will stand for any questions.
questions? Understandments?
Thank you, Senator. I just had a question on page 11 at the top on line 5, where it says a facility who materially violates this act fails to comply with the requirements of this, basically this law. So how do you determine materially? I mean, what would be the threshold for that? Is it just the department decides, or what would constitute that material violation?
Mr. Chairman, Senator Steinmetz, that is a great question. And
11.
we go into, because you're talking about page 11, lines 5, right?
Yes, correct.
For that, we have to go back to 35 to 1503 is where that is at. So that would be if they violate those sections, would be my understanding of how that's written, which would be pages 6, 7, 8, 9 to the lines 1 and 2 of page 10.
Mr. Chairman, follow up.
Go ahead.
y- Thank you for that. That's a great clarification. But what constitutes a material violation of that? Is it 1? Is it 5? Is it all of it? Is it not, part of it? How does that work? I'm just trying to figure that out. And maybe you need to phone a friend.
I might have to
Maybe
phone a
some
friend
people's
on why we
information
wrote it
of
this
that.
way and get back to you.
That's fine. And if you don't have it for this committee meeting either, we could always get an email telling us that too, but it's just a question I had reading through the bill.
Any further comment?
No, thank you, Mr. Chairman, Senator Steinmetz. I will get an answer to that because I do not remember why we wrote it that way.
Okay. Senator Hutchins.
Mr. Chairman, thank you. Senator Brennan, I remember this bill from last year or something similar. And one of the oppositions was, if we go to page 13, were those penalties, the violations. I'm fine with the violations, but what's changed from the last time we saw this bill to now? Is it the may? Was there a shall before? That's on line 3. Just wondering about the penalties. Like I said, it seemed to be a big issue last time.
Mr. Chairman, Senator Hutchings, thank you for that question. Yes, the penalties were a big discussion point last time on this bill, and that has changed. What has changed in a lot of this is the amount of the penalty. The penalties were much higher in the last bill. The last bill also prohibited a hospital from collecting payment from anybody if they were found to be out of compliance. This one imposes penalties on the hospitals, but not quite so onerous.
Okay, further? Okay, Madam Chairman, let's go back to regular committee and ask for public comment while she's coming back up. Anybody in the public want to come up and say a few words? Health Department. And then we're going to, as rapidly as possible, see if there's any other testimony. Mr. Fuchs, go ahead. Introduce yourself and go ahead.
Good morning, Mr. Chairman. My name is Franz Fuchs, Deputy Director of the Department of Health. Just here for any questions. We're happy to execute the law as written.
Committee, any questions? Okay, you're off easy on that one. Any public comments? Come forward. Fill the chairs or don't fill the chairs. Okay. You do, if you will, welcome.
Sorry.
And then if you'll state your name for the record and let us know why you're here.
I'm Heidi Kennedy and I'm from Gillette. And I love this bill. I think anytime there's transparency in the operation of any entity, it's better for all parties involved. And I apologize, I've never testified before. Living in Wyoming has some limitations when it comes to shopping around for medical services, especially in emergency situations. However, in non-emergency situations where you have time to take into consideration the many factors one weighs to make medical decisions, such as for maybe like a yearly mammogram or something like that. Pricing is one of many factors in making those decisions. Other considerations might be travel distance, ratings and reviews of the doctor, weather, road conditions, etc. But I do have maybe a suggestion. May I make a point, which from my perspective might make this bill better? I think it would be a good idea to also maybe include in this bill for hospitals to have available on their website the list of past versions of the list, if that makes sense. Like an archive of having you determine how long they have to archive those lists. I don't know. I would suggest maybe 3 to 5 years. Yeah. So that when you go in for service on, say, in December for something, you don't get your itemized bill for 6 months or whatever, and you have the opportunity to see the pricing at the time of service versus what they might currently have on their website. It's just a suggestion, and I don't know how all of this works, but that was just an idea. Thank you.
Okay, thank you. Committee, any questions? Thank you.
Thank you.
Mr. Boley?
Madam Chairman, committee members, Eric Boley, President of the Wyoming Hospital Association. And first of all, we want to thank you, Chairman, for meeting with us through the interim and working on this really important topic. Yes, last year we did oppose the bill for several reasons. And I think some of those have kind of settled. We were right at the beginning of the Trump administration last year. There were changes taking place to this program as we were testifying in this committee. And that was one of our concerns is if we create a state statute that is different than the federal rule, which of the two masters do we follow? And with that in mind, things just changed again January 1st. There was new direction given to us from the feds. I think the good news is this bill, we took the most recent guidance out of CMS, and this bill was drafted with those rules and requirements in place. So the way that we have to report the information is exactly what we are responsible for with the feds right now. And I would tell you, this is a complex situation and a complex idea. I don't disagree that shopping services makes a great deal of sense. And we're in support of this bill. We want to see this passed in the form that it's in. But I think the other thing to realize is that different than going to the grocery store, different than even buying a vehicle, you're going to be able to look at our websites and look at estimates. But when we get inside, when we start operating on someone, things change. And so the estimate's only as good as an estimate in certain circumstances. Now, the list price, the prices will still be listed, but a great example, and I think I shared this years ago when my wife and I were first married, I was playing basketball and I heard a loud pop in my knee, and I finally went to the doctor and they said that I had meniscus tears. And so we scheduled my surgery and I went down and they knocked me out. And 4 hours later than I was supposed to wake up, I woke up and freaked out. My wife was trying to hold me in the bed because I knew something had gone wrong. Well, when they got in there, not only had I damaged the meniscus, but I'd ruptured my ACL and they had replaced my ACL while I was out. I didn't have the ability to be brought out of anesthesia at that point and to look at pricing and decide whether or not I wanted to go to another doctor. That's a simple example, but when we get in and start looking at hearts and other things, I just think that we need to be realistic. So this does provide consumers the ability to shop services, but realize it's just an estimate. I think one of the other things that fails to get mentioned, and I mentioned this last year, is that consumers need to be better informed. And this is only one side of the equation. We're only dealing with the hospital pricing right here. We're not dealing with the insurance companies and how they pay, all of the acrobatics that we have to jump through when it comes to prior authorizations, denials, and all of those things. But I really believe this is a great first step, but I also think we need to take a look at the entire equation as we move forward and maybe think about other ways that we can help the consumers with such a complex issue. One of the questions you asked, Senator Steinmetz, and I hope this will answer it, but I'm going to use some examples, and I won't take a lot of time, but with these brand new rules that just came out from CMS, we had a big webinar for all of our hospital members. And there were some interesting statistics that were shared during that. And so this pricing transparency started with President Trump in his first term. And so in 2021 is when the first pricing transparency rules came out. During that year, there were 3,269 violations that were discovered. And for the first year, I wouldn't expect it. There's probably a lot of leniency, and as people try to find software companies that can manipulate and pull the information out. There were 0 civil monetary penalties levied by the federal government. In year 2, there were 3,800 total non-compliance actions and only 2 civil monetary penalties. Then in the next 2 years, these were during the Biden administration, 15,400 compliance actions. Of those, it equated into 12 civil monetary penalties. And then in the next year's there was 14,500 and there were 3 civil monetary penalties. And now that President Trump's back in office, in the first half of 2025, there were 3,240 total compliance actions, and they levied 10 civil monetary penalties. So they're enforcing it more and more. But what I would share, and this happened last year as we were sitting in this room, one of my hospitals received a letter from CMS and said, hey, you guys are out of compliance. And my hospital already knew that they were, but the violation, and I think this talks about these numbers, and this goes back to your question about materiality. So the letter was to let them know that the header on their website was located at the bottom of the page instead of the top of the page. And I think that a lot of these 15,000 are kind of silly things like that. And actually, if you look in the guidance, it doesn't tell us where the header has to be. It just says it has to be on our webpage. And so I think that we figured this thing out as we've gone along. With the new requirements that have come out, they were supposed to take effect January 1st, but CMS found that there was some ambiguity and some problems in their new guidance. And so they've actually given us until April 1st to be compliant. And now we've got our software companies that are struggling to meet those new requirements, but we will be in compliance. We're in compliance with the old stuff already, but we'll be in compliance with the new regulations by April 1st. And so I think when we talk about materiality, I would hope that the Department of Health doesn't have to spend their time telling us where the header should be located on our homepage of our websites. I think the other thing that my members have offered to do in support of this is they've talked about giving us direction as a hospital association, and we would build hyperlinks for each of the hospitals in the state so that people could come to our website and they could easily access every hospital website in the state and do their shopping if they want to do that. I do want you to realize, though, that all of this is unfunded. We've been forced by the federal government, and now the state's going to say, hey, you guys are going to do this. There's no funding for this. And estimates where that was only going to cost us $500 a year. It's laughable. We've got software companies that are making a lot of money off of this particular process, but we're doing it and we will continue to do it. We've had 2 weekly calls and we've talked about this upcoming legislation. Members are supportive. And I asked everybody, I said, I'm going to go testify on this in a couple of weeks. I need to know if you guys are in compliance or not. And I've heard from one of my smallest hospitals that they're struggling. They're in compliance through February, but their software companies told them it'll take 90 to 120 days to be able to fix their website and get them up to compliance. And so our hospitals do have it, but our small critical access hospitals that maybe have 6 or 10 days cash on hand, if they're lucky, they're struggling a little bit, but everyone is trying their hardest to be compliant. And I think that's the other thing that this bill allows when it talks about materiality. It gives the Department of Health the chance to say, hey, you guys are out of compliance, look at the situation. And then it's a staggered approach, which is very similar to what we already do. Our nursing homes are surveyed by the state through CMS once a year. Our critical access hospitals are surveyed by the state every 3 years. And our larger hospitals, the PPS, prospective payments, they actually pay to be surveyed by big companies that come in and do the survey. But when they're found to be out of compliance, they're not immediately fined or penalized. They're given a list of what's out of compliance. They then have time to create a plan of corrections and submit that to the state for approval. And then they have a timeline where they have to implement that plan of correction. And that's what this does. It mirrors what we're already doing with the state involved in other compliance issues. But then it also gives them the teeth to come in and levy fines if they need to, and take us all the way to where we can't admit patients, and our licensure might be in jeopardy. So we actually are serving two masters right now. We're serving the same master as far as what the requirements are. And then one other thing I would just say, as we've looked at data, and I'll share, one of our critical access hospitals shared with me, they've had software set up, they've had this on their website. In the last 5 years, their website's been accessed 7 times. And of those 7 times it was accessed, 5 were by their own compliance people. So it had only been accessed by 2 of the public. One of the things that we have found is the insurance companies are using this to go out and mine data so they can use that as they negotiate the rates that they're willing to pay us, and to try to put pressure on us to have us compare to other facilities, which is what the consumer can do. But right now, it seems that the consumer isn't using this nearly as much as others. But we still want to be good partners. We serve an important role in our communities. We want to provide this information to the consumer. And so we stand in support of the bill in its current draft. One other thing I would just say, I did talk with Senator Scott, and I think this is something that needs to be looked at in the future. One of our biggest fears is what happens if the feds change the playing field. And then we've got state statute that's codified with the language that's in it. And what if the feds change it considerably? And then we're back to that same position where we've got to decide which one we're going to follow. And so we've talked about potentially maybe putting a sunset date in so we can revisit this and make sure that our state statute still conforms with federal rules and regulations. And maybe at that time, we can take a look at how useful this information is and if there's something we can do to make it better. And with that, I'd stand for any questions.
Thank you. Committee, any questions? Senator Hutchings.
Thank you, Madam Chair. I agree with you on the sunset, kind of having built websites and you go out and you look and see who's looking and it's like, no one. Why waste your time? My question is on Ms. Heidi, who brought up archiving data. What do you think is the benefit of archiving for 6 months? What prices were there last month, at the last change? What benefit would that bring to you guys at all?
Madam Chairman, Senator Hutchins, I think it's a great question. I think it was a great point that she made too. And honestly, I'm glad the way she's thinking about it, about those regular, whether it's a colonoscopy or whether it's a mammogram, shopping those services. And we've seen that happen in certain communities. As far as archiving it, so basically we usually do one update a year, and it's when we go through our budgeting process. I don't know how onerous it would be, and I guess it'd be an interesting, something we could look into about trying to keep 2 databases going, what that looks like. Again, realize there's no funding for this. But what I would hope is that our hospitals are doing a much better job than taking 6 months to bill. Sometimes we run into snags when it comes to our payers, and sometimes payment takes a while. But we normally try to drop bills because we have timely filing responsibilities, that we try to get those bills dropped within 45 days. And I think we actually have a bill coming up after this that might kind of touch on that a little bit, but we could look at it. I just don't know the answer to that off the top of my head.
Senator Scott.
Madam Chairman, one question, and then when we get to working the bill, I will have a sunset date amendment.
Okay.
Madam Chairman, question is, why not just, okay, it's an important topic. The feds are working on it. Why are you saying we ought to work on it too, rather than saying the feds are handling this? We don't need to have to deal with 2 masters. Let us deal with just the feds. Why do you want a state law here?
Madam Chairman, Senator Scott, I think that's the $1 million question. And that was our argument last year, is this really necessary if we're already doing it? There is some skepticism from the general public and others that we're not complying and that we're not doing everything that we can. And there's also a big push nationally, especially through the Trump administration, to have states take action on this, because right now, everything that's happening federally is done through executive order. Congress hasn't acted on it and taken any action. And so there's the thought of whether rules at the federal level are strong enough to compete against statute on the state level. And so there's an attempt and a push to pass state law in every single state on this. And so we wanted to be a part of the solution as opposed to taking what we got.
Thank you. Committee, any further questions? Okay, thank you.
Thank you.
I see we have more public comment. Welcome. Please state your name for the committee and let us know your thoughts.
Thank you, Madam Chair. Jeff Doherty, representing Cicero Action. I'm going to be super brief because I know you've got things you need to move on to, but I just wanted to let you know, this is a bill we support. It was a bill we supported last year. We are so grateful to the previous speaker and his efforts to help us come up with a good bill here. I vigorously support the sunset. Matter of fact, as a supporter of Reigns, I support sunsets in a lot of the things that you do. So I think it's absolutely appropriate here. One other point, I think the reason why participation rates are so low in checking these is because it's historically been very hard to do. And I think the public isn't educated yet about the fact that this is available for them to conduct research, but I think it'll be an important tool. It is not a silver bullet for fixing healthcare, but it's certainly a step in the right direction. So Madam Chair, I'd urge the committee to support the bill.
Thank you. Committee, any questions? Right, thank you. Any more public comments? All right, with that, we will close public comment. Committee, what is your pleasure?
Move the bill.
Okay, bill has been moved by Senator Scott,
Madam Chairman.
seconded by Senator Steinmetz. Senator Scott.
Madam Chairman, this is a very complicated area and it's going to be difficult to get it right. So I think we do want to take this step of not being punitive and realize that this is going to evolve over time and we're going to improve what we can do over time and it's going to change. And I think a good deal of the difficulty, the example that Mr. Boley gave, the personal example, is exactly the kind of thing that happens that means that your final bill turned out a good deal different from what you thought it was going to be. And I don't think there's any getting away from that, Madam Chairman. So it is difficult getting full transparency in the pricing. The world is going to change. We are going to learn things. We're going to have to adjust this statute. It's a classic need for a sunset date. So, Madam Chairman, I would propose on page 15, to line 16, we insert a new section 3. This act is repealed effective July 1, 2029. I picked the date, Madam Chairman, to be the second general session year after the enactment of this bill. So that, I think, is a reasonable balance. The world have changed enough, so by then we're very likely to have to change something.
Second by Senator Hutchings. All right. Did we get that amendment?
Yes.
Okay,
And Madam Chairman,
yes.
we will have, you have to adjust a reference on the next page too. Because we put a new section, and that'll change the effective date, please.
Okay. Senator Scott, I want to thank you for bringing that to our attention. And I think that that's a great idea, especially since we've got a lot of things federally going on with this. And I think that gives us a chance to come back and review this and review how it's working and how we're lining up with what will be going on federally at that time. So this is a very friendly amendment. Further discussion on the amendment? Okay, All those in favor of Senator Scott's motion, please say aye. Aye. Opposed, no? All right, that amendment passes. Any further discussion on the bill?
Question.
Okay, question is being called. We're ready for the roll call.
This is a roll call vote for Senate File 57 as amended. Senator Crum,
Senator Crum has left an absentee vote of conflict.
Senator Hutchings.
Aye.
Senator Scott,
Aye.
Senator Steinmetz,
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 4 aye and 1 conflict.
Okay, thank you very much. All right, committee, it is 1:43. So what we're going to do is we are going to go on to our last bill. We might, we'll start working this bill and then we might hold over final thoughts on it for Wednesday, depending on how this bill goes. So next up for our consideration is Senate File number 122, sponsored by Senator Doc Stetter, and I believe he's here to explain the bill.
Thank you, Madam Chair. Members of the committee, bring you Senate File 122, Medical Necessity Standard Timeline Amendments. I'll give you a brief overview and make a quick notation of what changes in the bill. Essentially, we amend the number of days for an insured to determine the necessity of healthcare services, the time for a decision on what will be covered, taking it from 45 days to 21 days. Insurance companies appear to be dragging out the process. Often and that's what I hear from my local healthcare providers. Often we've heard that it may not even be adhering to the 45-day rule. Now, cash flow is the lifeblood of a rural hospital. I know that because in my other life, I sit through hospital board meetings and listen to their challenges, their dilemmas. The longer it takes to collect from the insurers, the more difficult it is to run our hospitals. Insurance companies need to be more reasonable and timely in paying their claims. For another dollar of interest, it appears that at least for the smaller hospitals, that for another dollar of interest, they drag it out in their decision making. We have our hospitals on the verge of collapse across this state in many instances. This allows the small operations and quite frankly, all healthcare services to have better cash flow. I came across, Madam Chair and committee, came across an interesting phrase as I was studying this and looking into it. And that phrase is delay, deny, downcoat. Delay, deny, downcoat. It's called payer wars. Trying to bring a bill to make some changes to address that. Madam Chair, in the bill, it's amending page 1, it's amending the number of days a healthcare insurer has to determine the medical necessity of the healthcare services. Page 2, we make those changes, moving it from 45 days on line 6 to 21 days. And that's the bill. That's what we're addressing. We're trying to improve healthcare and expedite the process of making sure our hospitals and healthcare providers are taken care of in a timely fashion. Thank you, Madam Chair. Members of the committee, thank you.
Thank you, Senator Doc Stetter. Committee, any questions? All right, thank you. We will go ahead and open this up to the insurance department. Thank you.
Madam Chairman, committee members, I'm Jeff Root. I'm the insurance commissioner. One, I just wanted to be here in case there were any questions since it's involved in the insurance statutes. But I just wanted to make one point in which we're currently looking into. As far as the numbers goes, for the external review, we have 15 IROs who are currently registered with our department. And we will be contacting them. We're going to try to contact them as quick as we can to see what's the impact here. Well, you know, if this goes down and the timeline is compressed, will they just not want to be registered with the state, or do they not care? When we looked across most of the states, it's pretty much, you see mostly 45 days. So we didn't know how this would impact them. There might be a large impact, there may not be any, but in any case, we wanted to look. we had approximately 16 of these determinations made on the for an external review in 2025. So the numbers are not large, but we'll see. We'll see what the impact is. But I'll here to help you with answer any questions you may have.
Thank you. Senator Steinmetz?
Thank you, Madam Chairman. So my question is, do you think this could be a consumer protection? Because, for example, we had a client not too long ago who fell through the cracks, didn't get his claims paid, was taken to court. And then the Corey is still fighting with the company to pay his legal fees for defending himself when the company dropped the ball. And so I really hope that this would help it would be a consumer protection as well, because many times consumers are contacted when the insurance company doesn't pay in a timely manner. They're sent to collections or they're taken to court. What is your experience on that? And do you think this might be a good consumer protection bill, regardless of what the companies might think?
Madam Chair, Senator Steinmetz, we've always had medical necessity in our statutes since I've been with the department. And so it's always been there. Now it's an individual who needs to avail themselves of it. So if Mr. Bowley's knee is being repaired and the insurance company looks at it and says, well, that wasn't medically necessary to do the ACL repair. He then has to ask for the internal review to the insurance company. And then if he doesn't like that answer, then we set up for the external review where we look to our list. Now that's always been there, but I'm actually rather shocked at the low numbers of people availing them to that. The prior year, I think in 2024, we had 25 where it actually went to an external review. In most of those cases, generally it's over half of them will be found in the consumer's favor. So it's well worth doing. And maybe it's just more of an educational thing that we need to take on.
Maybe so.
Any further questions? Right. Thank you. All right. Further public comment? Anybody? Any public comment online? Yes. Oh, go ahead. Come on up. Welcome.
Good afternoon, Madam Chairman, members of the committee. Kelsey Prestisator with the Wyoming Hospital Association. Just wanted to say a few brief words before passing it off to two of our members that are online and ready to testify. I just wanted to thank you first for the opportunity to testify today on this bill. As the sponsor of this bill mentioned, for our rural hospitals here in the state, timely appeal decisions are not just an administrative technicality. They are critical to cash flow and financial viability for our hospitals. In Wyoming, as many as 70% of our hospitals currently operate in the red, with most of them struggling to stay open and provide critical services to their communities. As claims are denied and the appeals linger, reimbursement is delayed. And in small critical access hospitals operating on narrow margins, those delays directly impact the ability for our hospitals to meet payroll, pay suppliers, and keep doors open for critical emergency care 24/7, surgery, and OB/GYN care. Rural hospitals are also often the largest employer in their communities and the only local source of urgent medical care. This bill is about ensuring that reimbursement disputes are resolved promptly so that rural facilities can plan, budget, and operate responsibly. With that, Ms. Chairman, I would like to turn it over to Mike Hunsaker, Chief Operating Officer, and Scott Graham, Chief Financial Officer of Star Valley Health, who I believe are online. And they belong to one of our state's critical access hospitals. And I'd like to pass it off to them to provide a frontline perspective on the impact that this bill would have on our hospitals. Thank you.
Thank you. Any questions? All right, if we can bring on our online testimony, that would be great. Welcome. If you'd state your name for the record and give us your testimony, please.
Hi, this is Dan Ordina, the CEO at Star Valley Health. Can you hear me?
We can.
Madam Chair, members of the committee, Thank you for the opportunity to testify. Obviously, the bill is about timely payment and basic communication between hospital providers and insurance companies. And when insurers delay payment or fail to communicate about a bill, the cost is shifted to providers, patients, and ultimately rural health systems. As been already stated, delayed payments strain cash flow for hospitals, clinics, and independent providers, especially in rural Wyoming. Patients are often caught in the middle, receiving bills or collection notices while claims sit unresolved. What the bill does is it moves the deadline for paying or denying a clean claim from 45 days to 21 days. It obviously does not dictate coverage decisions. It does not force insurers to pay invalid or fraudulent claims. Why the 21-day is reasonable is Medicare and many states already operate on timelines at or below 21 days. And the reason why 45 days is archaic is because of paper claims in the past. Now most claims are electronic and can be adjudicated within days. If an insurer can't determine whether to pay or deny a clean claim in 3 weeks, we believe that's a systems problem, not a provider problem. If a provider must pay staff, utilities, and vendors on time, and usually our net time frame is at a maximum 30 days, insurers should be able to meet similar expectations of hospitals. This simply aligns incentives towards timely professional claims handling. Obviously, enforcement remains with the Department of Insurance, and the bill strengthens, it just provides clarity to everybody that's involved in the process. So this is a pro-patient, pro-provider, and pro-accountability bill. It modernizes Wyoming law without expanding government or increasing costs. And at its core, it asks insurers to do what they already promise, pay valid claims promptly and communicate timely. Thank you very much.
Thank you. Any questions, committee? All right, thank you. How many more do we have online? We're running close to.
There's 2 more, Madam Chairman.
We don't have time to hear them either. Now you put
Okay, I think what we're gonna do, since we're running up against a time limit, is that and I apologize with those online, if you would please give us feel free to email us your testimony. We're gonna close the public testimony and go ahead and work the bill. So.
Madam Chairman, move the
Yes.
bill.
Moved by Senator Scott, second by Senator Steinmetz. All right. Committee, any discussion on the bill?
Question on the bill.
Okay, question being called.
This is a roll call vote for Senate File 122. Senator Crum,
Senator Crum has left an absentee vote of aye.
Senator Hutchings.
Aye.
Senator Scott.
Aye.
Senator Steinmetz.
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 5 ayes.
Okay. We are adjourned. Thank you, everybody. Thank you.
You'd ask a question.
Yeah.